Dr. Vanashree Nair. She'll be talking to us about residual cylinder and higher order aberrations.
Good afternoon, everyone. At the outset, I would like to thank Dr. Soni for including me in this wonderful IC. So I'm talking about 6 and 6 unhappy patients because of residual astigmatism or higher order aberrations. So as we all know, now cataract surgery has become a refractive surgery. Many of the patients, when they are taking premium IOLs, they are expecting 6 unaided vision. And this is one of the reasons why they are unhappy if they are left with a residual cylinder or some higher order aberrations which are causing an irritation. So just quickly recapitulating, what are aberrations? So basically we have mainly the lower order aberrations, 90%, which is defocus, that is your residual myopia or hypermetropia, astigmatism. And higher order aberrations are actually 10%, which are your most important ones being the spherical aberrations or the coma. So now when there is a small residual astigmatism, we feel that it's okay, just a 0.75 diopters, what will the patient feel? But this is how the image degrades. As you can notice on to the right side, the lower image is much sharper and the upper image has got slight, defocus kind of a picture or a slanting vision. So the patient may not really complain too much, but sometimes some patients can be, quite irritated with that kind of a vision. So we all know now that toric IOLs are giving us benefit when there is a pre-existing regular corneal astigmatism, more than 0.75 or 1 diopter. And we know that patients who have glaucoma, epiretinal membrane degeneration or any other oculopathology also we can implant these lenses. As multifocals are not advisable, but toric IOLs, yes, definitely we can go for them. Only place where we cannot use torics are irregular corneas and those who are wearing RGP or scleral contact lenses. So let's have a look at the biometry. Now, when we recapitulate our regular astigmatism, basically we have with the rule, against the rule, and oblique astigmatism. So when we look at the biometry and the refraction of the patient, just neglect the refraction. What was the patient wearing before cataract surgery? Because the lenticular astigmatism is going to go away. What is going to remain is only the corneal astigmatism. So that's what we need to study in the keratometry. Important point to remember is the with the rule and against the rule astigmatism. With the rule is where the vertical axis is your, the steeper axis, and against the rule is where the horizontal axis is your steeper axis. And in our old patients, it is the against the rule astigmatism which comes more into play. One more important aspect is the posterior corneal astigmatism. Now, many of the older refractometers are not taking into consideration the posterior corneal astigmatism, or there is a correction factor which is applied. The newer machines will, like IOL Master, they actually calculate the PCA, but LensStar will compensate for the PCA. And the online formulas will also compensate for your posterior corneal astigmatism, but that plays a very important role and we need to remember that. So coming to this example, here you can say this is a biometry printout from the LensStar. Here if you see that it is a clear cut, we can see the astigmatism where the arrow is, that it is almost 2.5 diopters. So we know that, okay, this is clear cut and we need to put a toric IOL for this patient. But here if you see this in this patient, the astigmatism which is showing is hardly 0.62. But remember, it is against the rule astigmatism. So it is at 3 degrees. So 0.62 is not the real astigmatism. We need to add 0.3 to the value of the cylinder. And actually the cylinder value which is there for the patient is 1 diopter. That's why the printout is telling us to use a T3 toric IOL, which becomes significant for the patient. Another example here, again, if you look at the right eye, it is showing just 0.45. But again, taking into consideration the posterior corneal astigmatism, the biometry is still telling us use a T2, and the corneal astigmatism is 0.66. If you leave this, probably you may get away with a 0.75 diopter at the end of the surgery. Patient may or may not complain, but you can take your chances. Now, there's a concept of small axis flip. Now, previously, the calculators used to leave a little more residual cylinder to avoid an axis flip. Now, what is this axis flip? If you're flipping the axis from with the rule to against the rule, that's bad. But now we know that we should actually leave a small with the rule astigmatism at the end of the surgery. So if you're flipping towards with the rule, it's okay. Your target should be actually to leave a 0.34 diopter astigmatism. Why? Because the cornea is always shifting from with the rule to against the rule. So say today you are having a 0-0 refraction, patient is happy. 5 years down the line, he's going to shift more towards against the rule. So hence it is better to target a 0.35 of with the rule astigmatism. So try to correct astigmatism because it will give a better quality of vision to your patient, making him 6/6 happy. With the rule astigmatism, 0.3 to 0.5, you can leave it alone, but try to correct all against the rule astigmatism. Quickly coming to aberrations, that is your higher order aberrations. So we have dealt with the low order things, and now coming to the higher order aberrations, what are important is the coma, trefoil, and most important being the spherical aberrations for our patients. So quickly, touching upon how we can calculate the higher order aberrations, it is basically done with wavefront aberrometry. We have three techniques, Hartmann-Shack that the Pentacam uses, then the topalizer using the churning, and ray tracing, that is your eye trace, basically gives the higher order aberration. So how do we quantify them? You use the Zernike polynomials or the Fourier analysis. Eye trace is a very wonderful device, very expensive. We don't have access to it, many of us, but then it gives a very nice analysis of all the internal aberrations. It gives separately for the cornea, for the total eye, and the lens also. Pentacam again is very helpful to give us the total high order aberration. So how are they actually affecting the patient? So they degrade the quality of vision. The third order being the coma and trefoil, and the fourth order spherical aberration. So here you can see how the retinal image is actually affected because of all the different aberrations. So in spherical aberrations, what happens is there is a point which spreads. So the E will look like all spreaded out. And why it happens is because of the peripheral light rays which are defocused in a spherical lens. So that's why the role of aspheric lenses have come in. So I'll quickly go into the way the eye changes. Okay, so now here if you can see, the cornea is having positive spherical aberration. The lens also has, the lens has negative spherical aberration. That's why a young person doesn't have much of spherical aberrations. But that changes as the patient becomes older. So in a cataract patient, you have both are having a lot of positive spherical aberrations, which will give you a little bit of depth of focus, but overall the vision quality is degraded. And because of paucity of time, I'll just go to one important concept. So we have something called as aspheric IOLs, which have either a zero spherical aberration or a negative spherical aberrations. So how these aspheric lenses actually work is the way they focus the light. So a spherical lens will give you a same power all over its curvature, causing positive spherical aberrations, but an aspheric lens will actually focus it for you. Now, some examples I would like to share that, the traditional IOLs like the Lensar is actually a positive spherical aberration lens. Our usual modern lenses, that is Acrosoft IQ, Technis, Vivinex, these are all negative spherical aberration lenses. So what they do actually is they'll counteract for the corneal positive spherical aberration, giving us zero spherical aberration to us. And zero spherical aberration is Envista. So just one few seconds I'll take. So what is important to remember is, in hyperopic LASIK or myopic LASIK, there's a lot of change in the spherical aberration that is happening. So in hyperopic LASIK, cornea is hyperprolate. That is, the Q has become negative. There's negative spherical aberration. So you use the standard IOL. Whereas if it is a myopic LASIK, you use a negative aspheric IOL lens. Take home points quickly. First and foremost, target the lower order aberrations, correct your defocus and astigmatism, your 90% problem is solved. Then focus on the higher order aberrations. Most important being the spherical aberrations. So do tomography to find out your higher order aberrations. If they are more than 0.4, then you avoid the multifocal lenses. Otherwise, you can safely go for the negative spherical aberration lens. Thank you so much.
Thank you, Dr. Vanashree, for that broad overview. So you would sum up saying that if you post myopic refractive surgery, you would go in for a negative aspheric lens and probably or a zero aberration lens, right?
So in a post-myopic LASIK, there is a lot of positive spherical aberration induced on the cornea. So we want to counteract that. Hence our aspheric lenses which are having more negative spherical aberration like Technis or IQ are better in those cases. And a hyperopic LASIK actually has negative spherical. So you can go in with sensor.
Okay. Thank you so much.